Hey, good afternoon. I thought I'd be able to study for two emergencies yesterday, but the old man wasn't feeling up to it. So today I'm going to study on upper gastrointestinal bleeding. As usual, my reference is Tintinalli's Emergency Medicine, with a little bit of adlibs spliced throughout the way. So let's begin. Upper gastrointestinal bleeding is any gastrointestinal bleeding originating proximal to the ligament of Treitz, which is basically the division between the upper gastrointestinal tract and the lower gastrointestinal tract, approximately near the duodenum. Differences in prevalence between countries is attributed to variations in Helicobacter pylori rates, socioeconomic conditions, and prescription patterns of ulcer healing and ulcer promoting medications. Increasing age, coexistent organ system disease, and recurrent hemorrhage are factors associated with increased morbidity and mortality. One of the most common etiologies of upper gastrointestinal bleeding is peptic ulcer disease. Despite a downward trend in prevalence over the past 20 years, peptic ulcer disease, which includes gastric, duodenal, esophageal, and stomal ulcers, is still considered the most common cause of upper gastrointestinal bleeding. Awareness that aspirin, nonsteroidal, anti-inflammatory drugs, and smoking cause bleeding and increased recognition of treatment of Helicobacter pylori infection may be responsible for its decreased incidence, especially in the developed world. Erosive gastritis, esophagitis, and duodenitis are also common causes of gastrointestinal hemorrhage. Common predisposing factors include alcohol intake, salicylates, and nonsteroidal anti-inflammatory drugs. Infection, toxic ingestion, radiation, and stress from severe illness may also cause erosive gastritis. Stress-related mucosal disease occurs in patients with overwhelming sepsis, trauma, or respiratory failure requiring mechanical ventilation. Candida, herpes simplex virus, cytomegalovirus, and human immunodeficiency virus are potential sources of esophageal bleeding from infection. Esophageal and gastric varices result from portal hypertension and generally are most often a result of alcoholic liver disease. Although they account for a very small percentage of all cases of upper gastrointestinal hemorrhage, they can rebleed and carry a high mortality rate. However, many patients with end-stage cirrhosis never develop varices. Many patients with documented varices never bleed, and many patients with a documented history of varices presenting with upper gastrointestinal bleeding actually bleed from non-variceal sites. It is the cause of upper gastrointestinal bleeding in cirrhotic patients 59% of the time, followed by peptic ulcer disease in 16% of cases. Mallory-Weiss syndrome is basically an exaggeration of gastroesophageal reflux disease. And when I mean it is an exaggeration, I'm not saying that the symptoms are just worse, but when a person has long-standing GERD, they may develop Mallory-Weiss syndrome. It is bleeding secondary to a longitudinal mucosal tear at the gastroesophageal junction. The classic history is repeated vomiting followed by bright red hematemesis. The syndrome can be associated with alcoholic binge drinking, diabetic ketoacidosis, or chemotherapy administration. The Valsalva maneuver, such as from coughing or seizures, is also a reported cause. Other causes include Dieulafoy lesions, which are arteries of the gastrointestinal tract protruding through the submucosa. They are commonly found in the lesser curvature of the stomach. Arteriovenous malformation and malignancy are other causes of upper gastrointestinal hemorrhage. Significant bleeding from the ear, nose, and throat may also masquerade as gastrointestinal hemorrhage. An aortoenteric fistula secondary to a pre-existing aortic graft is unusual but important to rule out in cases of patients with an aortic graft. This generally presents as a self-limited herald bleed with hematemesis or hematochezia, which precedes massive hemorrhage and exsanguination. When taking history of patients with suspected of upper gastrointestinal bleeding, we ask about hematemesis, coffee ground emesis, or melena. Classically, hematemesis and coffee ground emesis suggest an upper gastrointestinal cause. The presence of melena in patients with ages younger than 50 years old more likely indicates an upper gastrointestinal bleed versus a lower gastrointestinal bleed, which generally manifests with hematochezia instead, except in severe cases of upper gastrointestinal hemorrhage with severe blood loss. Hematochezia may also occur, especially with increased transit of the exaggregated blood. Vomiting and retching followed by hematemesis suggest a Mallory-Weiss tear. Be sure to ask about prior episodes of gastrointestinal bleeding and any interventions performed. If there is a history of an aortic graft, it could suggest bleeding from an aortoenteric fistula. Salicylates, glucocorticoids, nonsteroidal anti-inflammatory drugs, and anticoagulants all place the patient at a high risk for gastrointestinal bleeding. Alcohol abuse is strongly associated with a number of causes of bleeding, including peptic ulcer disease, erosive gastritis, and esophageal varices. Ingestion of iron or bismuth can simulate melena. Liquid medications with red dye, such as certain foods like beets, can simulate hematochezia. In such cases, stool guaiac testing may be negative. Although medical history may suggest the source of bleeding, history can also be misleading. What initially may appear to be lower gastrointestinal bleeding may be an upper gastrointestinal bleed in disguise. For example, I did mention that there are cases of hematochezia that could actually be due to upper gastrointestinal bleeding instead. So, for example, bright red or maroon rectal bleeding unexpectedly originates from upper gastrointestinal sources around 14% at a time. If patients volunteer that they have complaints of hematemesis or melena and there is no vomiting and the patient has not noted any tarry stools, signs may be subtle instead. Patients with hypotension, tachycardia, angina, syncope, weakness, confusion, or cardiac arrest may have underlying gastrointestinal hemorrhage. Visual inspection of the vomitus for a bloody maroon or coffee ground appearance is the most reliable way to diagnose upper gastrointestinal bleeding in the emergency room. Vital signs may reveal obvious hypotension and tachycardia, and more subtle findings may also occur, such as decreased pulse pressure or tachypnea. Younger patients and those without comorbidities can tolerate substantial volume loss with minimal or no changes in vital signs. Paradoxical bradycardia may occur even in the face of profound hypovolemia. Comorbid conditions and medications may mask the body's physiologic response to volume loss. Beta blockers, for example, will prevent tachycardia. Patients with baseline hypertension may have relatively normal blood pressure in the setting of hypovolemia. Cool, clammy skin is an obvious sign of shock, or hypovolemic shock in this case. Spider angiomas, palmar erythema, jaundice, and gynecomastia suggest liver disease. Petechiae and purpura suggest an underlying coagulopathy. Facial lesions, cutaneous macules, or telangiectasias may be suggestive of the Peutz Jeghers, Rendu, Osler, Weber, or Gardner syndromes. Generally speaking, you also look at the ear, nose, and throat because there could be occult bleeding resulting in swallowed blood and subsequent coffee ground emesis. Abdominal examination may disclose tenderness, masses, ascites, or organomegaly. Rectal examination is also performed to detect the presence of blood and its appearance, whether it's bright red, maroon, or melanotic. In patients with significant bleeding, generally speaking, you obtain blood for type and cross-matching in case transfusion is needed. A CBC is also important, however, initial hematocrit levels may not reflect the actual amount of acute blood loss. BUN creatinine, electrolytes, glucose coagulation, and liver function studies are also included because upper gastrointestinal hemorrhage will elevate BUN levels through digestion and absorption of hemoglobin. A BUN creatinine ratio of greater than or equal to 30 suggests an upper gastrointestinal source of bleeding. Coagulation studies, including INR, partial thromboplastin time, and platelet count, are useful in patients taking anticoagulants and those with underlying hepatic disease. An EKG is also requested in patients with underlying coronary artery disease. Silent cardiac or mesenteric ischemia can develop if bleeding decreases cardiac or mesenteric perfusion. A single elevated lactate level is a sentinel sign of severe illness. Routine abdominal and chest radiographs are not really of much value here, and they're not needed in the absence of any specific clinical indications. Barium contrast studies are contraindicated because barium may hinder subsequent endoscopy or angiography. In cases where traditional endoscopy is unavailable or endoscopic visualization is unable to find the source, consider tagged red cell scintigraphy or visceral angiography. Generally speaking, these tests will demonstrate the source only when there is active bleeding and localize the source of bleeding to determine whether medical or surgical management is optimal. Nasogastric lavage may also be performed in a subset of patients in which nasogastric intubation and aspiration are diagnostic and therapeutic at the same time. In patients without a history of hematemesis, a positive aspirate provides strong evidence for an upper gastrointestinal source of bleeding. High-risk lesions are more likely in patients with bloody aspirates. Visual inspection of the aspirate to identify bloody, maroon, or coffee ground material verifies upper gastrointestinal bleeding. Early nasogastric lavage is associated with decreased time to endoscopy. Placement of the nasogastric tube and lavage can confirm the diagnosis of upper gastrointestinal bleeding. However, a negative nasogastric aspirate does not exclude an upper gastrointestinal source. Intermittent bleeding, pyloric spasm, or edema preventing reflux of duodenal blood can cause false negative results. Nasogastric aspiration only yields a positive result in about 23 of patients without hematemesis with occult upper gastrointestinal bleeding. Guaiac testing of nasogastric aspirate can yield both false negative and false positive results. Conventional stool guaiac cards may be falsely negative. Even minimally traumatic nasogastric intubation can result in positive guaiac testing even in the face of a clear aspirate due to the blood that is derived from traumatic insertion of the nasogastric tube. Visual inspection of the aspirate for a bloody, maroon, or coffee ground appearance is the most reliable way to diagnose upper gastrointestinal bleeding. If bright red blood or clots are found in a nasogastric aspirate, perform gentle gastric lavage. Room temperature water is the preferred irrigant. Maintain the nasogastric tube on mild, intermittent suction. Vigorous suction may produce gastric erosions that can confuse findings on subsequent endoscopy. Generally speaking, there's no evidence to support any concerns that nasogastric tube passage may provoke bleeding in patients with varices. For upper gastrointestinal bleeding risk stratification, patients with very low risk are patients less than 60 years old without any major comorbidities, no history of red hematemesis, no hematochezia, negative nasogastric aspirates, hemodynamically stable at presentation, and with normal laboratory studies. And high-risk patients include those with advanced age, comorbidities, and prior endoscopic or transjugular intrahepatic portosystemic shunt procedures, red hematemesis, hematochezia or melena, positive nasogastric aspirates, hemodynamic instability, and abnormal laboratory studies. Initial management for these patients is stabilization of both vital signs and fluid. Patients in hemorrhagic shock may require immediate resuscitation, including large bore IVs, typed and cross-matched blood with consideration of massive transfusion protocols, and early airway management in some cases. Intubating a patient with an upper gastrointestinal bleed who is hemodynamically unstable can be perilous. Aggressively resuscitate prior to intubation first and consider using smaller doses of the induction agent to minimize peri-intubation hypotension or arrest. When upper gastrointestinal bleeding is severe, blood transfusions can be life-saving for these patients. Massive transfusion protocols may be required if a large amount of blood product is anticipated. When we treat upper gastrointestinal bleed, blood transfusion is often used if hemoglobin is less than or equal to 7 grams per deciliter in most. However, if the patient is older or has comorbidities, you can start transfusion at less than or equal to 9 grams per deciliter. We also correct coagulopathy, especially if INR is elevated or platelets are less than 50,000, so the patient has thrombocytopenia, or if bleeding is severe Correct coagulopathy unless contraindications arise for correction, such as stents. Omeprazole at 80 milligrams in an IV bolus, then infused at 8 milligrams per hour, is used for ulcer bleeding. Octreotide is also used, but for varices this time. For the elderly, begin it at a lower dose range of 25 microgram boluses with an infusion of 25 micrograms per hour. For non-elderly patients, the dose is 50 microgram boluses with an infusion of 25 to 50 micrograms per hour. Antibiotics such as ciprofloxacin or ceftriaxone typically are used for cirrhotics with upper gastrointestinal bleeding. There are also specific protocols for peptic ulcer disease antibiotic therapy. They usually involve either azithromycin or ciprofloxacin with metronidazole as well. In patients with life-threatening bleeding receiving anticoagulants, reverse the coagulopathy without concern for the INR unless there are contraindications to reversal, such as cardiac or vascular stents. In less severe bleeding, carefully consider the risks of reversal therapy. An INR of greater than or equal to 1.5 is a significant predictor of mortality in patients with an upper gastrointestinal bleed who are receiving anticoagulants. Proton pump inhibitors usually recommended for patients with non-variceal bleeding from peptic ulcer disease. When proton pump inhibitors are given at a high dose, the gastric pH remains neutral. Clot formation from platelet aggregation is dependent on a pH that is greater than 6.0. Administer a high-dose proton pump inhibitor such as omeprazole 80 milligrams through IV bolus followed by an infusion of 8 milligrams per hour because the cause of bleeding cannot be determined without the endoscopy. In patients with peptic ulcer bleeding, proton pump inhibitors reduce the need for surgery, the length of stay in the hospital, and signs of bleeding. Octreotide is used primarily for patients with variceal bleeding. It is a long-acting analog of somatostatin that elicits several actions in patients with upper gastrointestinal bleeding. It inhibits the secretion of gastric acid, reduces blood flow to the gastroduodenal mucosa, and causes splanchnic vasoconstriction. The dose is a 50 milligram bolus followed by a continuous infusion of 25 to 50 micrograms per hour, except in the elderly where the bolus is reduced to 25 and the hourly dose is also 25 micrograms. In patients with cirrhosis, they have an impaired immune system, and just like in patients with peptic ulcer disease suspected to have Helicobacter pylori infection, we also give them antibiotics. Erythromycin and metoclopramide are pro-motility agents that enhance endoscopic visualization. They are not recommended for routine use but may be considered if the patient is undergoing endoscopy in the emergency room and the patient is suspected to have large amounts of blood in the upper gastrointestinal tract. Endoscopy is the diagnostic study of choice. It allows visualization of the source of bleeding in most cases and administration of hemostatic therapy. Optimal timing relates to severity of the bleeding. Early endoscopy, within 24 hours of presentation, is recommended for most patients because it is associated with a significant cost reduction and the decreased length of stay in the hospital. An unstable patient may benefit from emergent endoscopy immediately following resuscitation. Endoscopic treatment options commonly used for variceal bleeding include variceal ligation and sclerotherapy. Clips, thermocoagulation, and sclerosant injections alone or in combination with epinephrine injections are used in ulcerative lesions. Balloon tamponade is an effective short-term solution for life-threatening variceal bleeding. Because of the high rate of complications, however, it should be reserved for temporary stabilization of patients, for transfer to an appropriate institution, or until endoscopy can be done. Patients who do not respond to both pharmacologic and endoscopic treatments may require surgery. In patients with variceal bleeding, shunt operations, which are transjugular intrahepatic portosystemic shunt procedures, and non-shunt operations such as esophageal transection or gastroesophageal junction devascularization may be utilized. In non-variceal bleeding, percutaneous embolization or subtotal or total gastrectomy can be performed. Emergent surgical consultation is considered prudent in the cases of uncontrolled bleeding.
When it comes to lower gastrointestinal bleeding, it is the loss of blood from the gastrointestinal tract distal to the ligament of Treitz. Lower gastrointestinal bleeding is a common problem in emergency medicine and should be considered potentially life-threatening until proven otherwise. It occurs less often than upper gastrointestinal bleeding with an annual incidence of approximately 36 per 100,000. Because blood must travel through the upper gastrointestinal tract down to the lower gastrointestinal system, upper gastrointestinal bleeds are the most common source of all causes of blood detected in the lower gastrointestinal tract. Among patients with an established lower gastrointestinal source of bleeding, i.e., bleeding past the ligament of Treitz, the most common cause is diverticular disease, followed by colitis, adenomatous polyps, and malignancies. It's more common among females and increases significantly in the elderly. Around 80% of episodes of lower gastrointestinal bleeding resolve spontaneously, however, this is hard to predict. Hematochezia is either bright red or maroon colored rectal bleeding. If hematochezia originates from an upper gastrointestinal source, it indicates brisk upper gastrointestinal bleeding, which may be accompanied by hematemesis and hemodynamic instability. Approximately 10% of hematochezia episodes may be associated with upper gastrointestinal bleeding. Molina is dark or black colored stools and usually represents bleeding from an upper gastrointestinal source proximal to the ligament of Treitz, but may also represent slow bleeding from a lower gastrointestinal source. Diverticulosis and diverticular bleeding is usually painless and results from erosion into the penetrating artery of the diverticulum. Diverticular bleeding may be massive, but up to 90% of episodes resolve spontaneously. Bleeding can recur in up to half. Although most diverticula are located on the left colon, right-sided diverticula are thought to be more likely to bleed. Elderly patients with underlying medical illnesses, those with increased needs for transfusion, and those taking anticoagulants or non-steroidal anti-inflammatory drugs have increased morbidity and mortality. Vascular ectasia, which includes arteriovenous malformations and angiodysplasias of the colon, is a common cause of lower gastrointestinal bleeding. Vascular ectasia can also be present in the small bowel and is difficult to diagnose. The development of vascular ectasia in the large bowel seems to be due to a chronic process and increases with aging. Ischemic colitis is the most common cause of intestinal ischemia and is usually transient. The colon is predisposed to ischemia because of its poor vascular circulation and high bacterial content. Aneurysmal rupture, vasculitis, hypercoagulable states, prolonged strenuous exercise, cardiovascular insult, irritable bowel syndrome, and certain medications that cause vasoconstriction or slow bowel motility are known risk factors. Diagnosis is usually made by endoscopy. Although most cases will resolve on their own, up to 20% will require surgical intervention. Mesenteric ischemia can lead to bowel necrosis. Causes include thrombosis or embolism of the superior mesenteric artery, mesenteric venous thrombosis, and non-occlusive mesenteric ischemia associated with low arterial flow with vasoconstriction. Diagnosis is difficult and the presentation can mimic other intra-abdominal pathologies. Diagnosis requires a high index of suspicion, especially in patients who are older than 60 years of age and in those with atrial fibrillation, congestive heart failure, recent myocardial infarction, postprandial abdominal pain, or unexplained weight loss. Meckel's diverticulum consists of embryonic tissue, most commonly found in the terminal ileum. More than half of lesions contain ectopic gastric tissue, which can secrete gastric enzymes, eroding the mucosal wall and causing bleeding. It is rare but important, especially in the younger population. So, common causes of lower gastrointestinal bleeding include upper gastrointestinal bleeding, diverticulosis, gastrointestinal carcinoma, angiodysplasia, arteriovenous malformations, mesenteric ischemia, ischemic colitis, Meckel's diverticulum, hemorrhoids, infectious colitis, inflammatory bowel disease, polyps, radiation colitis, rectal ulcers, trauma, foreign bodies, carcinoma, prostate biopsy sites, endometriosis, Dulafoy lesions, colonic varices, and portal hypertensive enteropathy. Factors associated with a high morbidity rate for lower gastrointestinal bleeding are hemodynamic instability, repeated hematochezia, gross blood on initial rectal examination, initial hematocrit of less than 35%, syncope, non-tender abdomen, which is predictive of severe bleeding, aspirin or non-steroidal anti-inflammatory drug use, which is predictive of diverticular hemorrhage, and more than 2 comorbid conditions. Although most patients will volunteer complaints of hematochezia or Molina, signs and symptoms of hypotension, tachycardia, angina, syncope, weakness, or altered mental status can all occur as a result of lower gastrointestinal bleeding. We ask about previous gastrointestinal bleeding and a history of pain, trauma, ingestion, or insertion of foreign bodies, and recent colonoscopies. As mentioned earlier, diverticular bleeding tends to be painless, tends to occur more on the left side of the colon, but tends to bleed more on the right, so pain is an important factor here. Weight loss and changes in bowel habits may suggest a malignancy. A history of an aortic graft may suggest the possibility of an aortoenteric fistula. Medications such as salicylates, NSAIDs, and warfarin can increase the risk of lower gastrointestinal bleeding by affecting hemodynamic factors. Ingestion of iron or bismuth can stimulate melena, and certain foods such as beets can stimulate hematochezia. Hypotension and tachycardia or decreased pulse pressure or tachypnea develop with significant bleeding. However, changes in vital signs may be masked by concurrent medications as mentioned earlier. Cool, pale skin and an increase in capillary refill can be signs of shock. Physical findings of liver disease as well as petechiae and purpura suggest an underlying coagulopathy. The abdominal examination may disclose tenderness, masses, ascites, or organomegaly. A lack of abdominal tenderness in patients with lower gastrointestinal bleeding suggests bleeding from disorders involving the vasculature, such as diverticulosis or angiodysplasia. Inflammatory bowel disorders with lower gastrointestinal bleeding are associated with abdominal tenderness on examination. Thorough examination of the rectal area may reveal an obvious source of bleeding, such as a laceration, masses, trauma, anal fissures, or external hemorrhoids. A vaginal or urinary source of bleeding mistaken for a gastrointestinal source can be identified by further examination and testing. A digital rectal examination is performed to detect gross blood, either bright red or maroon, and for guaiac testing. Can also detect the presence of masses, such as, again, external hemorrhoids or other masses that are present. Endoscopy can be performed at the bedside, though we don't usually do it. So it is helpful in the cases of internal hemorrhoids, which cannot really be appreciated through digital rectal examination. CBC coagulation studies and typed and cross-matched blood are important because these patients may need transfusion. They may have deranged hemodynamic factors due to severe blood loss and the like. Coagulation studies are of benefit in patients taking anticoagulants or those with underlying hepatic disease. Blood urea nitrogen, creatinine, electrolytes, glucose, and liver function studies are also obtained, and the initial hematocrit level may not reflect the actual amount of blood loss, especially in acute brisk bleeding. Bleeding from a source higher in the gastrointestinal tract may elevate blood urea nitrogen levels through digestion and absorption of hemoglobin, but in the lower gastrointestinal tract, not so much. Silent ischemia can occur secondary to decreased oxygen delivery accompanying significant gastrointestinal bleeding. Angiography, scintigraphy, or endoscopy, being the initial diagnostic procedure of choice, depends upon ability to obtain these resources and preference of the clinician. Angiography can sometimes detect the site of bleeding and help guide surgical management. Moreover, angiography permits therapeutic options such as transcatheter arterial embolization or infusion of vasoconstrictive agents. However, angiographic diagnosis and therapy require a relatively brisk bleeding rate of at least 0.5 milliliters per minute. Serious complications may also occur with angiography in up to 10% of cases. Again, treatment is if the patient is unstable or actively bleeding, we resuscitate them, we administer oxygen and institute cardiac monitoring, replace their volume with crystalloids, correct coagulopathy, give blood transfusions if necessary. Consider the placement of a nasogastric tube if lower gastrointestinal bleeding is significant. Hematochezia unexpectedly originates from upper gastrointestinal sources approximately 10 to 14% at a time. General guidelines for initiation of blood transfusion are continued active bleeding and failure to improve perfusion and vital signs after the infusion of 2 liters of crystalloid. Flexible sigmoidoscopy can evaluate possible distal colonic and rectal sources of bleeding, but cannot identify more proximal sources of bleeding. Colonoscopy can diagnose various sources of lower gastrointestinal bleeding, such as diverticulosis, angiodysplasia, and polyps, masses, malignancy, especially when samples are taken and a biopsy is performed eventually, may allow ablation of bleeding sites with various endoscopic hemostasis methods such as injection sclerotherapy, electrocoagulation, heater probe therapy, banding, and clipping. If colonoscopy fails to determine the source of bleeding, specialists may consider upper endoscopy to evaluate for upper gastrointestinal sources of bleeding, although upper endoscopy may be indicated first in certain situations. Timing of endoscopy can vary. Some studies suggest that urgent colonoscopy is both safe and accurate within 12 to 24 hours of admission, but others report that delayed colonoscopy is appropriate in more stable patients. Variables that are associated with morbidity include hemodynamic instability, repeated hematochezia within 4 hours of evaluation, a non-tender abdomen, aspirin use, and more than 2 comorbid conditions. Thank you very much.